Hi, everyone. It's about a minute until we will be kicking off this webinar. I'm Connie Lee, and I am the CEO of the Alliance to Cure Cavernous Malformation, formerly the Angioma Alliance. We are in our August webinar right now, and we're going to wait just a minute as people roll in. I can see the counters already going up. While we're waiting, I just want to remind folks that there is a support group immediately after this, and I believe Darla will be somewhere lurking in the participant list if you check it, and she will be dropping the link to the support group in the chat at various times during the meeting. She'll probably do it now. She'll definitely do it at the end. You just click on it, but you got to click on it before we shut the webinar down because it just disappears after that. If you have a question, there will be time for questions and answers at the end of the webinar. We won't be answering them in the middle. Please use the Q&A. You can see that right on your screen there at the bottom. It says Q&A. That's where we'll look for your questions. We will not be looking for them in the chat. So if you take the time to type them in the chat, nobody's going to see it and nobody's going to answer it. So that is unfortunate, but is the best way that we can manage it because there's usually so many. All right, so let's kick it off. This is neurological considerations in cavernous malformations, and I am joined tonight with Dr. Kelly Flemming and Dr. Kelsey Smith, who are both here from Mayo. Um, I'm going to introduce Dr. Flemming, and she will introduce Dr. Smith. Dr. Flemming is a neurologist at the Mayo Clinic in Rochester, Minnesota, and she serves as the medical director for the CCM Center of Excellence there. She also is the vice chair of our medical advisory board. In addition to her clinical responsibilities, Dr. Flemming runs a research project dedicated to investigating the natural history of CCM illness, and most of the important natural history papers that are in the literature have her somewhere on the author list, often as first or last author. Her research aims to better understand the long-term behavior of CCM lesions and how these activities affect the human condition. And she has been maintaining a prospective research registry to track her patients' lifestyle factors, medical history, and treatment over time. Welcome, Dr. Flemming.
Thank you. It's good to see everyone, and I'm just very thankful that to be invited by Connie and the board to again talk about neurologic considerations with some special emphasis on women's issues. I'm going to try to share my screen here, and we will get started. All right. Sorry, I got the Zoom screen is in my. Okay. So again, I'm going to talk about neurologic considerations in patients with cavernous malformations. I'm going to give a little bit of background first, and then we're going to introduce Dr. Kelsey Smith, who's with me today, and I'm thankful that she is with me to talk about the seizure aspects. So there are our disclosures. And for the first few minutes, I'm going to talk about how a neurologist approaches a patient with cavernous malformations. Then I'm going to talk a little bit about what's new in the neurologic section of the guidelines that were updated in 2025, talk a little bit about what research we're doing at Mayo Clinic, and then move to talking about some female-specific issues, pregnancy and hormones in regards to hemorrhage risk. Then I'm going to turn things over to Dr. Kelsey Smith, one of our fantastic epilepsy colleagues, who's going to talk about seizure disorders associated with cavernous malformations, and again, specifically with an emphasis on women's considerations. So I always like to start very basic, and this talk is aimed at patients. And so I'm sure you all know what a cavernous malformation is, but we start very basic, and then we'll kind of move on from here. As you know, there's arteries that drain into capillaries that drain into veins, and a cavernous malformation is kind of this lesion that's at the level of the capillaries, that instead of forming a tube, it forms up this bubbles of capillaries, and these bubbles are caverns, and they're lined with what's called endothelium, the lining, and they can occur in the spinal cord, they can occur in the brain. And when they occur in the brain, we can often see some of those little bubbles on the MRI. This is a patient that has a cavernous malformation in the brainstem, and you can see the little black and the white bubbles are reflective of that pathology. And at the very microscopic level, what's dysfunctional is the tight junctions. The glue that holds those endothelial lining together is leaky. And so when it leaks, that blood can get into the surface of the brain and cause symptoms like headaches, seizures, or neurologic deficits. And when I approach a patient with a cavernous malformation, I go through 4 different steps. The first thing I think about and review with patients, I look at the imaging and say, is this a cavernous malformation for sure, and not something else like a brain tumor or infectious nodule or something else that might mimic a cavernous malformation. The second thing I think about is it the sporadic form? So is there a single cavernous malformation, often with an associated developmental venous anomaly or DVA? Or is it the familial form, in which case you often see multiple cavernous malformations? Importantly, I always ask myself, is the reason the MRI was done, um, is the cavernous malformation causing those symptoms that led to the MRI? Not uncommonly, somebody might have head trauma or a common migraine, and a cavernous malformation is found incidentally or accidentally. But this is important because it influences the natural history. So the second thing I go over with patients once I secure the diagnosis is I try to help them understand what's the risk if we left the cavernous malformation in, what's the risk of a bleeding episode happening, or what's the risk of a seizure? Because we want to weigh that information against what is the risk of taking that cavernous malformation out. So treating the lesion. And lesion, cavernous malformation, mass, it all means the same thing. Sometimes we use the word lesion and people get confused, but we're talking about the cavernous malformation. So we look at the natural history. What's the risk of leaving it alone versus what's the risk of doing surgery or radiosurgery or laser interstitial thermal therapy or focused ultrasound? And then we talk about treating the symptoms related to the lesion. So some patients that have seizures, we not only try to decide if the cavernous malformation needs to be removed, but we put people on seizure medication. Or if somebody has double vision and it persists after a hemorrhage in the brainstem, can we do surgery to help that? And then the fourth thing I always consider is I look at the whole person and are there other medical conditions the patient has or medications the patient has that might influence the cavernous malformation natural history. And so I think at all of these different steps, a neurologist can play an important role in the management of patients with cavernous malformations, in addition to the neurosurgeon that often sees you. And for neurologists, these are the typical questions I might get asked is, here's a patient where you see all these little black dots on the susceptibility weighted MRI, and people ask me, are those cavernous malformations or are they something else? And if they are cavernous malformations, can this patient have a heart valve surgery that they need to be on blood thinner? Here's another patient that has familial cerebral cavernous malformation syndrome, where each of those little black dots is a cavernous malformation. And this is a patient having seizures, and I might ask somebody like Dr. Smith to see this patient and help me figure out which cavernous malformation is causing the seizure so we can direct the surgeon to the appropriate spot. And then here's another patient with the cavernous malformation in the brainstem here, and patient wants to know what's the risk of bleeding and can she be on oral contraceptives. So these are common questions that we get asked as neurologists. And so moving to the next section, what's new in neurology? As many of you know, the guidelines for the diagnosis and clinical management of cavernous malformations was updated this year and published in the journal Neurosurgery. And there are sections on genetics and sections on surgical approaches, but there's also a neurologic section. And so I just want to highlight a couple of those things that were in the new guidelines compared to the old guidelines. So one of the things that we emphasized was lifestyle changes that might either reduce the risk of hemorrhage or reduce the number of cavernous malformations that patients with familial form may have. So one of the things that was added compared to 2017 was the information on the diet, that we recommended that a diet low in processed foods and emulsifiers may be considered, given the information of the influence of the gut microbiome on cavernous malformation formation. And there's a great prior webinar on diet and the app that's useful for identifying emulsifiers that Connie or Darla could refer you to if you haven't seen it. It's a great webinar. We also added physical activity, aerobic exercise, hiking, biking, swimming. None of these you can't run too fast to make cavernous malformations bleed. So aerobic activity is just fine, does not increase the risk of bleeding. In terms of high blood pressure, it has not been found to be a risk factor for cavernous malformation hemorrhage, but in one study on familial patients, it was blood pressure that was well controlled was associated with a lower lesion count, so less cavernous malformations than those that had untreated or um, blood pressure that was above the goal. The current goal is less than 130/80. We also added a part on mental health because we know that up to 30 to 40% of patients become very anxious after the initial diagnosis of cavernous malformation. And so identifying that anxiety and referring patients to appropriate resources is important. And then mild to moderate alcohol has not been noted to be an increased risk of bleeding, but there was a few cohort studies that noted binge drinking, drinking more than 4 drinks at a time might increase the risk of bleeding. And so again, for general good health, as well as cavernous malformation hemorrhage prevention, we recommended limited alcohol. The guidelines also are helpful for clinicians like myself and others to help us decide when headaches might be related to the cavernous malformation versus be a primary headache disorder. So primary headaches, you might think of migraine or tension headaches or cluster headaches. Those are common in the general population and probably slightly more common in patients with cavernous malformations. But patients with cavernous malformations can also have an acute hemorrhage or bleeding episode. The cavernous malformation may compress the spinal fluid structures and cause something called hydrocephalus in the brain, where there's a backup of spinal fluid. And occasionally you'll see the trigeminal nerve be compressed by either the cavernous malformation or a developmental venous anomaly. And the trigeminal nerve usually gives a sensation to the face, but when it's compressed, it can give you facial pain. And so again, the guidelines were updated with the International Classification of Headaches Disorders so that us clinicians can identify patients, which patients are having headaches that are related to cavernous malformation. So I think that is helpful. The other thing added to the guideline that applies to some select patients is that the use of non-aspirin NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, Advil, Aleve, can be used with caution in certain patients. And usually I think of using it in people where the cavernous malformation is non-hemorrhagic, or it's one of these, what we call as Abramsky type 3 or 4, the really tiny ones that look very benign. These NSAIDs can be used in patients like that. So talk to your individual doctor. Everyone's situation may vary, but if you've had a recent hemorrhage, we generally caution against these medications. I usually tell people if it looks like a very benign cavernous malformation or hasn't ever bled, that 1 to 3 times a month is probably not a bad amount of times, but we don't like people overusing NSAIDs for a variety of reasons besides cavernous malformations. Also in the guidelines are additional things about certain medications that might be potentially harmful, potentially beneficial, and then somewhat neutral. So one of the things that seems paradoxical is that people can that blood thinners don't increase the risk of bleeding from a cavernous malformation. And I'll show you in a future slide a little bit about why that might be true. But in big studies where they put a lot of patients together with cavernous malformations that had to be on blood thinners for some reason, often atrial fibrillation or a pulmonary embolus, which is a blood clot in the lungs, the risk of bleeding was not high from the cavernous malformation. So if people have a life-threatening condition or something serious that they need to be on a blood thinner, having a cavernous malformation doesn't prevent that. Also added to the guidelines were a statement about thrombolysis, which is a fancy word for clot busting. So sometimes we use these clot busting medications for either ischemic stroke or for blood clots in the lungs. And so again, it's weighing the risk and benefit of each of these medications. So if somebody had a large ischemic stroke where they were going to be disabled by it, and they had a small cavernous malformation that maybe hadn't bled, then maybe using a clot busting agent might be considered. Whereas if they had a smaller ischemic stroke or a non-life-threatening condition, we might think of other things in our toolbox to treat this stroke. I'm going to talk a little bit more about female hormones in a few minutes, but there may be some increased risk with certain female hormones. At the time of the writing of the guidelines, the CASH EPOC study had not yet been published. So the CASH EPOC study was comparing atorvastatin 80 milligrams daily to a placebo in patients with symptomatic cavernous malformations. And atorvastatin you may recognize as a cholesterol-lowering drug, but there's other reasons why it might prevent that endothelium, that lining of the blood vessel, from being leaky. And that study has now been published, and there was no difference in the group on atorvastatin versus placebo in terms of benefit or risk. So we know that there may not be a benefit to it at the dose they studied and at the time frame they studied, but there's not a risk either. Propranolol is a medication you may have heard of for migraine headaches. It's used for essential tremor. It's used for blood pressure and sometimes pulse rate. Um, it was looked at in the TREAT CCM trial. There was about 83 patients in that trial, where 2/3 of patients received propranolol and 1/3 did not. And um, at the end of that trial, we know that the propranolol was safe and tolerated, and there seemed to be some potential benefit of the medication in reducing hemorrhage risk, but the study wasn't powered. It didn't have enough patients to really look at that effectiveness. So the long-term effectiveness or efficacy is not known in that medication. And then there's a couple of studies that low vitamin D levels may correlate with hemorrhage risk, but nobody's done a study where half of you get vitamin D supplements, half of you get placebo, and see what happens. So that study has not been done, but we still think it would be reasonable to supplement vitamin D, especially in people at risk for deficiency or on seizure medications that may cause deficiency. Um, s- so now moving toward a couple of the things that we've been up to in the last year or two is, since 2015, we've had a collection of patients that were consented kindly to allowing us to contact them every year and see how they're doing. And we've been following them over time to see what is the hemorrhage risk. How do these cavernous malformations evolve over the time? Do they change enough that warrants repeat MRI every year? And last year we published some data on the natural history of cavernous malformations, what's the bleed risk, and looked at a couple of specific factors on um, MRI findings that might help us predict who's going to bleed versus not bleed. We've also seen a number of patients that get diagnosed with cerebral amyloid angiopathy, a completely different condition than familial cerebral cavernous malformation syndrome, but sometimes they get confused with each other. And so last year we published some criteria for other physicians and radiologists to help them distinguish the two entities, so that doesn't get confused, because they're very different in what happens to people. Myself and the group at the Alliance updated the gene review on familial CCM that is helpful for clinicians. And then the other thing we looked at was the number of cavernous malformations that occur in familial patients. And we looked at a whole bunch of different risk factors. And the only one that stood out in our small study was tobacco use seemed to be correlated with a higher number of cavernous malformations. I had the great pleasure of working with Dalal Bektas over the last year. She was a visiting neurosurgery fellow from Switzerland. And there you see Dr. Lanzino in the picture. And Dr. Lanzino designated us as the Cavernous Malformation Task Force. And so um, he had Dr. Bektas working very hard, and she was able to do multiple projects, 8 or 9 papers over the last year, and including one that was on tailored management of cavernous malformations in women. And so I'm going to share a little bit of information from that article that she wrote. So one thing that people encounter is pregnancy, and does that increase the risk of bleeding? Does it increase the risk of seizures? And there were some papers in the early 1980s, 1990s suggesting a few case reports of patients having a bleed during pregnancy. And so there was this concern early on that pregnancy increased the risk of cavernous malformation hemorrhage. Subsequently, three studies that had larger numbers did not show a significant increase in risk of bleeding during cavernous during pregnancy. And so there's been this kind of controversy about whether the pregnancy increases risk or not. Overall, the overall risk is very low, but part of the problem is a lot of women get diagnosed with cavernous malformation after their childbearing years. So the absolute number of women that have been studied is fairly low. And in two of the studies, there were certain assumptions made about the length of pregnancy and accounting for miscarriages and such. And so sometimes that can influence the actual numbers in these papers. Um, so there is an ongoing multi-center collaborative that I'm involved in that we're trying to look at even more numbers and put all of our data together to try to answer this question more definitively. Hopefully within a year we'll have that data. Until then, these are the things that I go over with patients when I encounter someone that wants to consider pregnancy and has a cavernous malformation. The first thing is timing. So if a patient has had a hemorrhage, we know that the highest risk of another hemorrhage is in the first 2 years. So we talk about whether it's appropriate or possible for somebody to delay pregnancy, or what's the best timing in their situation. And again, it may have to do with how frequent their seizures are, and that's when I would get Dr. Smith involved. In patients with the familial form of cavernous malformation, we often talk to genetic counselors, and in some cases, fertility doctors as well. Um, then patients with cavernous malformations and seizure disorders, again, I often refer these on to people like Dr. Smith, Dr. Burkholder at Mayo Clinic, to say, can this patient stay on this seizure medication during pregnancy, or should they be switched to a safer one? Um, how do we monitor this patient during pregnancy? And folate supplementation is very important for preventing complications from some of the seizure medications, and so important to take early on. During pregnancy, we monitor for any focal neurologic deficits, stroke-like symptoms, seizures, headaches, and we can do an MRI without contrast fairly safely if there's any concern of something new going on. And again, if somebody has a seizure disorder, the medication may need to be monitored and the dose adjusted. For most, vaginal birth is fine. We consider a cesarean section in people where if they had a medical reason that they need a cesarean section, or if they've had a recent brain hemorrhage, or if they have a neurologic deficit, weakness on one side that precludes them from having a vaginal birth. And then after birth, again, the patient's seizure medications may need to be monitored, because as the maternal blood volume goes down, the seizure level or the medication level may change, and the dose need to be adjusted back to that from the pre-pregnancy state. So I think early discussions with physicians to decide on timing, preparation, prevention of complications is important. And the risk we still think is quite low. The absolute risk of any complications during pregnancy is quite low, but proper monitoring and having the right team is important. So I just tell patients to get yourself a team. Obstetricians often put you all in a high risk category, even though the overall risk is very low. But whenever there's something in the brain, it often escalates somebody to a quote high risk. Um, make sure your neurologist and or neurosurgeon are aware that you're pregnant, so that if there are other things that need to be done or considered, they can be involved. And again, fertility doctors and or geneticists as needed for patients with familial cavernous malformations. These are three different patients, patient 1, 2, and 3. Um, each has a panel A, MRI, and a panel B. The panel B is after they were started on some type of birth control. 2 of them were oral contraceptives and one was a Mirena IUD. And what you can see in panel B is that each of these patients had an enlargement or a hemorrhage of the cavernous malformation. And we started to see this pattern and wondered, is this anecdotal, like this just happened by circumstance, or does birth control or menopausal therapy increase the risk of brain hemorrhage from cavernous malformations? And how do these medications influence seizure disorders or seizure medications as well? So you might ask, well, why would estrogen or progesterone cause a cavernous malformation to hemorrhage? And I'm going to show you this little video that one of our artists put together, which shows normal artery to capillary to to vein blood flow. And when blood flows smoothly, it doesn't clot. If you put a cavernous malformation in there, blood is not moving as quickly, and when blood slows down, it likes to clot. And if you add something like estrogen, which is procoagulant, and a couple of those bubbles clot, the blood can't get out to the venous side, and maybe it goes into the brain. So that's one of the theories why aspirin, as we talked about previously, might reduce risk of bleeding, whereas estrogen, which can cause capillary and vein clotting, might increase the risk of clots within those bubbles. And estrogen does so by the dose and the type and the combination of progestin that it's combined with. Um, and we'll come back to that shortly here. Um, The second theory is something Dr. Jun Zhang and colleagues have been writing about in basic science research, suggesting that progesterone may negatively influence the CCM complex. So the CCM complex are the proteins that are made by the CCM genes that help that endothelial lining, that lining of the blood vessel, from being leaky. And so progesterone may negatively affect that complex that helps that lining. So with those two theories in mind, we combined our female patients that at Mayo with that of Essen, Germany, and we looked at 722 patients, 137 of whom had taken a female hormone at some point after diagnosis of the cavernous malformation, and 585 had never been on a estrogen or progesterone in the time of follow-up. And what we found was that 33% of the patients that had been on a estrogen or progesterone had I shouldn't say recurrent bleed, but any hemorrhage. They had a hemorrhage after their diagnosis versus 15.6% in the never female hormone group. So I'm always an optimist. So in the female hormone group, that's a 70% chance of not bleeding. But it was double the risk of those people that hadn't been on a female hormone. And that was even after adjusting for prior hemorrhage, brainstem location, and age. And when we looked closer at the data, if you looked at all the estrogen, progesterone, different varieties of delivery systems, if you looked at all of them together, those that were on a female hormone had a 1.6 times higher risk of bleeding compared to those never on any. If you isolated just the oral contraceptives, it was a 2-time higher risk. And if somebody had oral contraceptives plus were currently smoking, it was a 4.9 higher risk. And those are the similar relative risks that you see with deep vein thrombosis, so leg clots and oral contraceptives. So very, very similar to those risks. When we looked at menopausal hormones, if you looked at them all together, it was not statistically significant between the two, except if you isolated the oral estrogen out. The trouble with studying this is many of you know there's just hundreds of different formulations of birth control, estrogen, progesterone, and then there's different delivery methods, injections, vaginal, transdermal patches, intrauterine devices, and there's synthetic and bioequivalent estrogens, and there's just so many different kinds, and cavernous malformation patients are fairly rare, so it's a very difficult thing to study. And so I don't think we have all the answers, and I would consider our study that we published 2023, I think, as very exploratory. And we're hoping in the next year to gather a little bit more detailed information. In that exploratory study, we didn't look at the dose, for example. We didn't look at the type of progesterone that was combined with the estrogen, or if people were really compliant in taking it, and for how long were they taking it. Sometimes we relied on whether a medication was mentioned in the health record, which is not always accurate. And so there are some limitations to that study. And then some of the female hormones, the formulations didn't exist in Germany and the US exactly the same. And so there was a little bit of differences in some of the hormones, progesterone only hormones that we looked at. So what do we do with this information that has some limitations and we still have a lot of unanswered questions? And I usually tell patients caution is advised, but the absolute risk is low. I'm more concerned if somebody had a recent brain hemorrhage or they have growth in the cavernous malformation than if they have a tiny, what's called a Zabramski type 3 or 4 cavernous malformation or an incidental, accidentally found cavernous malformation that hasn't hemorrhaged. And I'm more concerned about oral contraceptives than transdermal estrogen or vaginal estrogen. Transdermal means like the patches or there's gels and sprays that go on the skin. Um, Now, some people, because they have surgical menopause or they have polycystic ovarian disease, there are certain things that people need to be on estrogen and progesterone. And those are the folks that I have consult with women's health or a gynecologist to try to pick out what's the lowest dose estrogen that might be helpful for their condition. What's the delivery method that's appropriate for their condition? Because again, the transdermal and vaginal estrogens are less concerned than oral. Here's a couple of real world examples. This patient had this enlarging cavernous malformation in the brainstem, um, and it was getting bigger, and she was having some gradual progressive symptoms. And she had a Mirena IUD, and we asked her to remove it. Despite removing it, it still grew, and she did eventually have to have surgery anyway. Um, This patient has CCM2. She had a symptomatic lesion removed from her temporal lobe that was causing seizures, and the only other spot, cavernous malformation that she had was this tiny little, what's called a Zabramski type 4. Um, and so we continued her on oral contraceptives and have just been monitoring her MRI scan. Um, and thus far, she's doing very well. So a couple of words on menopause, and I'm not an expert on this. And again, I always generally get the women's health group to help me with these. But back when I first started in after residency, the Women's Health Initiative came out, and HRT, hormone replacement therapy for menopause, was kind of a no-no because there was concern about breast cancer and concern about risk for clotting. But since that time, a lot of the data has been reanalyzed, and there may be benefits for women in the early menopause, the ages 50 to 60, and there's certainly benefit for people that have early premature menopause or surgical menopause. And so again, talk to your doctor about what if they recommend HRT, and if so, what might be safe in your situation. Vaginal estrogen we know is very safe and does not increase the risk of clotting. Transdermal is so skin patches are slightly safe are safer than oral, but still have some mild risk. There are some non-hormonal alternatives for vasomotor symptoms, so hot flashes and sleep issues. SSRIs, which are anti-anxiety medications, but also help for these symptoms. And then something called Viaza is new in the last couple years. But again, I think discuss this with an expert in the field, and we have to weigh the risk benefit ratio between what you need um, to get through whatever condition or symptoms that you have, and then depends on the cavernous malformation and kind of how active it is. And I think we're going to find with this study that we're doing um, is that there's going to be certain MRI features that might predict which patients have a higher risk with the female hormones, and certain characteristics, like if somebody's smoking, And oral contraceptives are going to probably be more concerning than something like menopausal therapy. But I think we're going to find more over the next year with this multi-center group that's trying to study this. So now I'd like to turn things over to Dr. Kelsey Smith, who's one of our experts in epilepsy, and she does a lot of a variety of different things with epilepsy, including some of the monitoring that we do for in selecting patients for surgery, but also has an interest in women's health. So I'm going to turn things over to Dr. Smith.
All right. Thank you. Let me make sure I share my screen here. And you guys can see my slides. I need to move this. Okay. All right. Move a couple things here. All right. So thank you for that introduction. So now I'll talk some about kind of seizures in general and then kind of focus in on women's health issues and issues for females with seizures in the setting of cavernous malformations. So we know that seizures are one of the most common symptoms associated with cerebral cavernous malformation. So when the cavernous malformation is in the brain. And there's been some studies that have looked at the risk of seizures associated with the cavernous malformations in the brain. And some of that data is from the familial forms. And so there's about a 20% risk of seizures in childhood for people with the familial forms, but that risk increases throughout the lifespan up to about 60% by the time people reach the age of 80. And some studies have suggested that that risk of seizures is about the same between the familial form and the sporadic form of cavernous malformations. But we know that the number of cavernous malformations, in addition to the location of the cavernous malformation, influences the risk of seizures. And we know that the temporal lobe is the area of the brain that likes to have seizures the most. And so anything that irritates the temporal lobe can increase the risk of seizures, especially cavernous malformations. So the cavernous malformations in the temporal lobe have that highest risk of patients having seizures. We know that anti-seizure medications in general are the first line treatment for seizures, and there may be other indications for removal, for surgical removal of cavernous malformations, like if they've bled in the past. But a lot of times, if seizures are the main symptom, then the main treatment is the anti-seizure medications, and we have a whole list of anti-seizure medications we can choose from. Um, and that list has increased throughout the years. And we know that most patients will have control of their seizures on anti-seizure medications, but there's still probably about 25 to 35% of patients who may not have control on anti-seizure medications. And in those scenarios, we may even think about a more epilepsy-specific surgery. And that's when we're trying to record seizures, understand exactly where they're coming from, and what else we can do for the seizures in epilepsy. And we know that when seizures are present, there's many important considerations for females with seizures when we're talking about anti-seizure medications and family planning. And that's kind of what the rest of my slides will focus on. So when we talk about special considerations for seizure management for females, this really goes across the lifespan. And we can talk about times during puberty, birth control and oral contraceptives, family planning, pregnancy, and then also in menopause and special considerations that we need to think about for our female patients who have seizures. So first, when we talk about puberty, we know that there's a lot of hormonal changes that occur around puberty and with menstrual cycles. And when we talk about how that influences seizures, we know that hormone changes can influence seizure control in someone who has a history of seizures, no matter kind of what that cause of that epilepsy or seizures is from, but including cavernous malformations. We know that many patients who have seizures can recognize that there may be seizure worsening at different times during a menstrual cycle. And it's thought that this is in part due to these hormonal changes where estrogen levels are higher, seizures are more likely to occur. But then when progesterone levels are higher, seizures are less likely to occur. And so the term catamenial epilepsy has been defined as this kind of seizure doubling or seizures exclusively during a certain period of the menstrual cycle. And the most common times that we see seizure worsening during a menstrual cycle is perimenstrual, so either right before or during menstruation, and then in mid-cycle around ovulation. And it's really felt that those hormonal fluctuations and those higher levels of estrogen can lead to worse seizures at those times. If we recognize that there's this kind of pattern of seizures worsening around the menstrual cycle, then usually we can either adjust anti-seizure medications, add an additional anti-seizure medication, or if it's safe from the standpoint of the cavernous malformation, consider hormonal treatment with either like an IUD to suppress menstrual cycles, or kind of working with our gynecology colleagues if there's a hormonal treatment that could be helpful but still safe from the standpoint of the cavernous malformation. If patients are on oral contraceptives and have a seizure disorder and are on anti-seizure medications, there's also important to consider that there can be this two-way interaction between contraception and anti-seizure medication. So some of our anti-seizure medications can make oral contraceptives not effective because they change their metabolism and metabolize them too quickly, so they don't suppress the ability to get pregnant. And so it's important to note that if someone's on an oral contraceptive, but on an anti-seizure medicine with a list here of medicines that can cause oral contraceptive failure, that their risk of pregnancy can be higher. And if that is the case, but the patient doesn't want to get pregnant and it's safe to be on, a contraceptive or needs to be on a contraceptive for another reason, then usually the safest, most effective contraception in these patients is an intrauterine device or sometimes a long-acting progesterone. And we work with our gynecology colleagues to make some of these decisions. But we also know that anti-seizure medications can lower the level of we know that oral contraceptives can lower the level of some anti-seizure medications, most notably lamotrigine. And so we have to be aware of this bidirectional interaction between contraception and anti-seizure medications to make the best decision for patients. It's important to recognize this because in general, when you look at the rates of unintended pregnancy in patients with seizure disorders, it's actually really high as 50% of the pregnancies in patients with epilepsy, and that's epilepsy of any cause. About 50% can have unintended pregnancies. And so kind of talking about these things early is important. When we talk about pregnancy planning in patients with seizure disorders, I think there's a few questions that are really important. First, are they on an anti-seizure medication? And do they really need to be on that anti-seizure medication? What's the risk of recurrent seizures? If they need to be on an anti-seizure medication, what's the safest for the baby and the mother? And then also, we recommend folic acid supplementation because there could be a reduced risk of major congenital malformations or issues with the baby. In general, if someone is on anti-seizure medications before pregnancy, if they have that indication to be on anti-seizure medications, then typically there's enough typically the risk of stopping them is higher than the risk of continuing them. And that's because we know that seizures during pregnancy are not good for the baby. They can lead to increased risk of preterm delivery, other complications if there's falls associated with seizures. We know that estrogen levels go up very high during pregnancy, and that estrogen can make seizures more likely to happen because it's pro-convulsant in nature. But then, against medication, always considering the risk-benefit ratio is, first of all, do they need to be on the anti-seizure medication? And second of all, what is the risk of that anti-seizure medication to the unborn baby? Luckily, over the past several years, there's been a number of registries that have been collecting data about the safety of anti-seizure medications during pregnancy. And a lot of this data has been growing. 20 years ago, we didn't have all the data that we have now. but there's the European registry, North American registry, and then registries as well in the UK and Ireland. The other good news is that they're all showing pretty similar results across studies. This is a table taken from an article that summarizes some of this information of some of our most common anti-seizure medications. And what we see consistently across these registries is that, first of all, the highest risk anti-seizure medication is valproic acid or Depakote in terms of major congenital malformations. And there's also studies that show that there's risk of problems with cognitive outcomes, higher risk of autism and ADHD with valproic acid. While the lowest risk anti-seizure medications across the studies have been levetiracetam or Keppra and lamotrigine or Lamictal. And so typically if we have someone who's of childbearing age that needs to be on an anti-seizure medication, we're trying to use one of our lower risk anti-seizure medications early, and that's usually Keppra or levetiracetam is the other name, or lamotrigine or Lamictal. But there can be different kind of considerations. A lot of our newer anti-seizure medications, we just don't have enough data on because it takes years to collect this data to have a large number of patients. The other thing that the studies have shown is that this is a dose-dependent relationship when we look at the risk. And what that means is that the higher doses of the anti-seizure medications are associated with higher risk to the baby. And so we want someone on the lowest dose that they need to maintain seizure freedom. So in terms of when we talk to patients about planning pregnancy when they need to be on anti-seizure medication, I think first of all, early counseling and preparation is important so that we can have someone on the safest medication early. Recommending females of childbearing age to take folic acid, and we typically recommend that to any female of childbearing age who are on anti-seizure medication just to try and reduce the risk, knowing that the rate of unintended pregnancy is pretty high. If we can, we'll simplify the anti-seizure medication regimen to one medication as opposed to multiple, and the lowest dose that is needed. And then it's also important to get a baseline anti-seizure medication in patients before pregnancy. So we have a target of kind of what to shoot for because we know metabolism changes significantly during pregnancy, and usually doses of anti-seizure medicines need to be changed. So I think a few important notes about pregnancy in patients with seizure disorders is that majority of patients, if they have seizure control before they get pregnant, then most patients can maintain that seizure control throughout pregnancy. And there's been data to support that. And the majority of those with seizure disorders or epilepsy have healthy pregnancies and can have a healthy babies. But during pregnancy, it's important to monitor symptoms and seizures and document seizures because we want to have the best seizure control possible. And then the metabolism in the body changes significantly during pregnancy, and anti-seizure medication levels should be typically followed anywhere from every trimester to monthly, kind of targeting the baseline anti-seizure medication level that was prior to pregnancy. And doses of many medications need to be increased. And that's been shown for our two safest medicines, that levetiracetam and lamotrigine. Typically, we need to increase the dose significantly so that the body's seeing the same level. If recurrent seizures do occur, it's important to look for common causes, to usually check the anti-seizure medication levels. And if there are new neurologic symptoms, then as already been mentioned, that an MRI without contrast could be done if needed. After delivery in patients who have seizure disorders, if the anti-seizure medication was increased during pregnancy, then the metabolism pretty quickly goes back to baseline. And so we need to make reductions in the anti-seizure medication back to that usually around the baseline dose prior to pregnancy. Some studies and some guidelines are out there regarding epilepsy, and breastfeeding. And breastfeeding can have many benefits for both the mother and the infant. And in general, the benefits of breastfeeding outweigh the risks, but it's important to monitor babies for the side effects of anti-seizure medications, which is usually they could be sleepy if they're taking in the breast milk and getting exposure to anti-seizure medications. But like I tell patients in clinic is that if you're breastfeeding, the baby gets a lot smaller exposure than they actually do in utero during pregnancy. And a lot of our anti-seizure medications that adults are on, we also use in babies if needed. And so a lot of times the benefit of breastfeeding outweighs the risk if the mother chooses to breastfeed. And then it's important after someone has a baby to talk about some postpartum safety. A lot of times, sleep deprivation in many patients with seizures can make seizures more likely to occur. So if there can be help at night for nighttime feedings or things like that, can be a good idea. And we know that there's a risk of postpartum depression in anyone after having a baby, and it can be higher in patients with seizure disorders, and to monitor for postpartum depression. And then just a couple slides here on menopause and seizure disorders. This is I think a strongly understudied area with limited data available for looking at menopause hormonal replacement therapy and its influence on seizure disorders, and then also looking at when patients have seizures, how does that influence menopause? There's just not many studies out there, and most of them are from kind of the late 1990s and early 2000s. So there have been some studies that suggest that patients with seizure disorders are at higher risk of earlier menopause. And those numbers from the studies are quite small, and trying to do more studies to look into this to try and confirm that. And then there is one study that had a small number of patients that looked at patients being with epilepsy given menopause hormones and to look at seizure control. And what they found in this small study is those patients on higher doses of the menopause hormonal treatment actually had seizure worsening, 71% did, while if they were on the low dose of the hormonal treatment, 50% had seizure worsening. And so these were statistically higher than those on placebo. And so this paper that was published in 2006 had raised some concern about using menopause hormones in patients with seizure disorders. As kind of was mentioned previously by Dr. Flemming, a lot of these older studies for menopause looked at these older hormonal preparations that are not currently really being used. And so there haven't been studies that have looked at the newer hormonal formulations and the influence on epilepsy. And so it's unclear if those would really increase the risk. But we do know that any hormones can have interactions with anti-seizure medications, similar to how oral contraceptives do. And so those interactions are important to be aware of to either adjust anti-seizure medications as appropriate. And again, we work closely with kind of women's health colleagues when making any decisions about hormonal treatments in general. The other thing I would just mention is that one of the biggest risks for osteoporosis is menopause, and that's for any female, is that once estrogen levels drop at menopause, there's a higher risk of osteoporosis, and with it comes higher risk of bone fractures. Then you add on this higher risk that we see in patients who have seizure disorders on anti-seizure medications with a higher risk of osteoporosis. And so we know that the risk if someone reaching menopause who's on anti-seizure medications is quite high for osteoporosis. So a lot of times we're considering calcium and vitamin D supplementation. And recommending weight-bearing exercises that can be good for the bones, and then considering DEXA scans. And if it's identified that patients have osteoporosis, then working with someone from endocrinology to think about treatments to try and help with the osteoporosis to prevent fractures in patients. So it's also an important consideration to think about in aging females on anti-seizure medications. And I think that was the end of my slides here. So maybe I'll stop share.
Thank you. Thank you. This has just been fascinating. And for those of you who aren't paying attention to the Q&A at this moment, Dr. Flemming has been busily answering 21 questions during this presentation, and I believe that you can see those answers as if you open up the Q&A, even if you haven't put your own question in there. We have just a few minutes, and I think I want to pull a couple of questions that have come up a few times, and a number of people have been asking about normal hormonal fluctuations. For example, when you're menstruating, do we know yet anything about whether you're more likely to hemorrhage when you're menstruating, whether your CCM symptoms are more likely to be exacerbated during menstruation? Is there any data yet that we can look at that is not seizure?
Yeah, I mean, it's a great question. And I've had people at the Alliance meetings, patients come up to me and tell me about symptoms are more common during that time, and it hasn't been studied yet. And so part of this multi-center collaborative that we're looking at this in the next year, some of those questions have to do with menstruation and fluctuating symptoms. But right now, I don't know of any literature that explains that.
Okay, and there's no way for us to track whether hemorrhage is more common during any particular point in the cycle.
I mean, we'd have it to try to study that. You'd have to. I mean, a lot of the medical documentation just doesn't include that in the history taking. So it would have to be collected, I think, prospectively data.
Okay. Um, I have a question here from someone who is asking about daily low dose aspirin. And this is a person whose high risk OB recommended that they take it because of concerns about preeclampsia. And they were wondering if that is something they should be worried about, given that they also have cavernous malformations. And then,
Yeah,
I'm sorry, and they're asking also, how do doctors decide which concern takes priority?
yeah. I mean, that's always the trick, and hopefully we involve you in the decision making of that as we try to go over what the risk of each thing is and have a conversation where you're involved in that decision making. But in general, again, we've seen that aspirin seems to, at least in some of the cohort studies, reduce the risk of bleeding. And again, because possibly it's those little bubbles that clot that the aspirin is preventing that. So I have a number of other women too that are taking aspirin or heparin during pregnancy and don't seem to have any issues with that. So I think it's probably very safe. I don't know that person's particular history if they've had a recent hemorrhage in their brain or not. But we look at the brain scan, we look at the reason the doctor preeclampsia puts you on that and kind of weigh the risk benefit ratio together.
Okay. Do we have any actual numbers on how much safer transdermal estrogen is versus oral? Is there a percentage or, you know?
Yeah, I posed that question to one of our women's health experts, and she just said like again it's sort of they sit down, have a conversation that here's the risk of the medication. Do you want to take that risk or not? But it's less in terms of risk of DVT, so blood clots in the legs, which to me, I always tell patients go to the gynecologist if they don't know what a cavernous malformation is. Tell them what would you do if somebody had a deep vein thrombosis? What kind of estrogen would you use? So at least the person I talked to said that transdermal is much safer than oral. And again, depending on what the cavernous malformation looks like, that's the transdermal that's used for menopausal therapy is it's much lower dose than that used for contraceptives. But I don't have a absolute number for you right now.
Okay. All right. A couple of people have asked about being on anti-seizure medicines in the past, after you're off of them, are there any lingering effects that you should be worried about, either affecting babies during pregnancy or osteoporosis that, even though you're no longer on it, might be affecting you?
So I think if you're off the meds, most of those risks go away. Some of our older anti-seizure medications had kind of longer lasting effects, like phenytoin, that can make people kind of unstable when they walked and affect the brain, and some bone issues that might last a while. But a lot of our newer anti-seizure medications, those risks, if you're off the anti-seizure meds, probably go away and would go away with pregnancy as well, because most of it is that direct exposure of the baby to the anti-seizure medication. So if someone were off of it, that risk pretty much goes away for the most part.
Excellent. Okay. We are almost at the top of the hour, and we do have some questions left. A good number of them are not directly related to the topic of this webinar. Um, This webinar has been recorded and will be up on our YouTube channel within a couple of weeks. So if you are asking them these wonderful physicians to repeat something, you can just go back and review the video when it goes up on YouTube. I want to thank both of you. This is fascinating, and I always love seeing you and learning from you. And just again, reminding folks that there is a link to the support group in the chat. And so if you want to continue the conversation with Darla and with the other folks that have been watching this, that is a very perfect and appropriate place to do it. So thank you very much. Have a wonderful rest of your evening, everyone, and we'll see you again next month. Thank you.
Thank you.
Thank you.
Thanks, Kelsey.